Still's disease. So what I would basically say is I would keep it very crisp since we're already about 25 minutes late. So the reason to choose this whole seminar or webinar was basically, I lost a couple of patients with adult Still's disease, who basically were presented late, or who other differentials were not thought of adequately, and immunosuppression was given, and they did not do well. So that's the reason I thought I should bring this topic up. Okay. Now, I'm from Bangalore. For those physicians who have joined in and who are kindly patiently waiting for the Q&A, we would take up at the end. Apologies for the delay. So I'm a rheumatologist from Bangalore, from Manipal Hospitals. So what I would start with is with a quick case. She's actually my own schoolmate sister, and that put things into a very difficult situation, because she initially came in under a physician, then I got involved, and then ID got involved, and to convince them that they have this disease, to convince myself with conviction that I have to immunosuppress, and after later on she's in a chronic pain situation now. I'll show you one of the sequelae of this disease is a chronic AOSD. And to convince myself everything that I've did right thing is something which I thought I should share. So a 37-year-old previously fit and well female with 4 weeks history of fever, chills, 102 degrees, with no rashes, no palpable lymph nodes, organomegaly. Mother had Hodgkin's in complete remission after treatment. She had sore throat as well. So initially she got admitted under physician, and all the infectious screen was ruled out with blood culture, urine culture negative, HIV, HBsAg, hepatitis C, chikungunya, dengue negative as well. So high inflammatory markers, and you see that high white cell count and neutrophilia. Ultrasound abdomen was done initially by the physician, that was normal. Ultrasound neck showed some right anterior cervical lymph nodes, not that high size, I must say, 8 by 4 mm. And lymph node basically was marked, and then a biopsy was done, which showed that gram stain was normal, culture was normal, gene expert TB culture normal, autoantibody screen was normal, complements normal, and peripheral smear showed neutrophilic leukocytosis with toxic granules. Ferritin was high, if you see, 1836. LDH was high, and there was mild moderate transaminitis. So the PET CT we asked, obviously at this stage we are looking at lymphoma, and then we got the PET CT done, which basically showed metabolically active right cervical lymph nodes, and some serositis was there, and they said that this inflammatory pathology. There was some uptake in the bone marrow and enlarged spleen. So basically they said reticuloendothelial stimulation. And ultrasound marking was done, as I told, and then lymph node biopsy was done, which basically showed reactive paracortical hyperplasia only. And some of the few words which were important, which have been, when I went through the literature review, was basically with possible some immunoblasts which are seen, and lymphocyte and macrophage infiltration, and basically there was no malignancy. Bone marrow aspiration and cytology was a reactive picture only. So hematology was involved, and the hematologist thought that there was no lymphoma here. So in my mind, before I thought about immunosuppression, I made this summary that this my classmate sister was having fever, polyarthralgia, no overt synovitis, sore throat, lymph nodes, and which was basically non-infective or non-malignant, with leukocytosis, neutrophilia, transaminitis, raised ferritin, raised inflammatory markers. So at this stage, I was fairly okay to say that this was adult onset Still's disease. And before I talk about what happened to her, let me just go through a few slides about Still's. So it was George Frederick Still who described in kids with the term Sogia, which came about 1897. Briefly, it was also termed as Weissler-Fanconi syndrome with fever, polyarthritis, lymph nodes, rash, sore throat, and leukocytosis of unknown origin. However, in 1971, Bywaters came up with this term of adult onset stills in 14 adults case series with same onset of symptoms. Epidemiology, if you see that usually it's a female disease, about 70% of affected patients are females with median age at 36 years. And mostly they say second trimester of pregnancy and postpartum would increase the disease recurrence. When you see the genetics, there's no strong association, I would say, but HLA-B35, BW35 was identified as a susceptibility antigen and also with mild self-limiting pattern of disease. DRW6 was associated with the occurrence of proximal arthralgia, and there was also association of AOSD and HLA-B17, 18, 35 and DR2. So with chronic AOSD, DR2 and DR5 have been associated, and DQ1 has been associated with chronic and systemic AOSD. So what it is seen is that gene mutation of this MIF gene, that is macrophage migration inhibitory factor, was seen to influence the plasma MIF levels in AOSD and contributes to disease susceptibility. Certainly it has a susceptibility factor here. And SOGIA has also been associated functional polymorphism of IL-6 gene and therefore IL-6 levels. So and monocyclic systemic AOSD frequently is seen with HLA-DR-B114 allele. So no consistent results have been obtained with HLA association. So if you look at the triggers, true broad category, infections and malignancies. Infections mainly viruses, rubella, measles, Coxsackie, Ecovirus 7, CMV, Epstein-Barr, HH6, parainfluenza, adenovirus, Hep B, C and parvovirus. With respect to bacteria, Mycoplasma, Chlamydia, Yersinia, Brucella and Borrelia. So clear responsibility has not been established, but you can have an interplay with genetic host factors, host genetic factors and autoimmunity mechanisms, and usually has also probably a pathogenic antigen presentation role. In terms of malignancies, it was solid cancers, that is 60% of cases, breast and lung, and hematological malignancies, usually 40% malignant lymphoma. So in immunopathogenesis, I'll come to the flow picture. Main start is through these PAMPs or DAMPs, which is pathogen associated or damage associated molecular patterns, which actually lead to inflammasome activation, which is NLRP3. This triggers the activation and secretion of pro-inflammatory cytokines, mainly being interleukin 1 beta and IL-18, and then through Th1 and Th17 activation. So it has got both role in innate and adaptive immunity, as opposed to in autoinflammatory, which is mainly innate. So upon TLR7 activation, dendritic cells get activated with Th17 response and neutrophil recruitment, and IL-1 beta upstream with secretion of TNF alpha, IL-8, IL-6, and which in turn has its own IL-1 receptor activation in an autocrine way. IL-6 is also a major cytokine which is responsible for the liver synthesis of ferritin and fast release in the blood. IL-18 has an NK cell activation and mediation of interferon gamma production, which increases macrophage activation. So it is this NK cell cytotoxicity impairment which is basically leads to this hemophagocytic lymphocytosis, which most frequent one being secondary to perforin deficiency. Decreased perforin expression was reported in SOGIA. Then pro-inflammatory IL-1 beta, whose activation results mainly from caspase-1 mediated cleavage to inflammasome activation, was higher in patients than in controls in studies with stills. IL-18 is another strong pro-inflammatory cytokine processed again through inflammasome machinery, which induces the production of Th1 mediated cytokines. So it's IL-18 was found higher in AOSD patients' sera, especially in the biopsy samples. IL-6 was more found in the rash and correlated with the disease activity in the serum levels. IL-6 responsible for clinical manifestations, as we all know, with fever, skin rash, and acute phase proteins, mainly ferritin. TNF-alpha was found to be increased in sera, but does not correlate with clinical disease activity as opposed to other rheumatoid-like diseases. And then chemokine CXCL8 is a major neutrophil inducer in this disease. So TLR7 ligation promotes recruitment of neutrophil and application of Th17-driven inflammatory response. And expression of TLR7 were actually correlated with AOSD activity, along with serum levels of IL-1 beta, 618, and interferon gamma. After remission, you saw that the TLR7 levels came down, and the main inflammasome was NLRP3, which I have already told involved in the AOSD pathophysiology. There is also, mainly problem in the Treg mechanisms. So the circulating levels of CD4, 24, 25 high Treg cells and TGF beta are inversely correlated with AOSD activity scores. High levels of Tregs would correlate with actually better prognosis of disease, is said. So if you see in a genetically predisposed individual, there is usually no family history in this case as opposed to autoinflammatory syndromes with certain polymorphisms of MIFs and IL-18. When they're exposed to PAMs or DAMs through the infections or malignancies, or even through reactive oxygen species or ER stress, there's NLRP3 activation and macrophage activation because of that, leading to activation of both innate and adaptive immunity, and production of cytokines through cytokine bursts through NK cell mediation. So main ones being IL-6, IL-18, IL-1 beta, and to some extent TNF and IL-8. There's also delayed resolution phase with reduced Treg cells and decreased NK cytotoxic function, reduced IL-10, which are all the anti-inflammatory cytokines basically. So you see that there is a PAMP and DAM dominant phase and a RAM dominant phase, that is delayed resolution pattern. So there's an argument, but is this an autoinflammatory disease? What goes in favor of that is an evidence of link with the microorganisms and absence of autoantibodies or autoantigen specific T cells. However, there's no familial cluster as we see in autoinflammatory, no ethnic groups, no geographic areas. So you can say that it has been at the crossroads of multigenic, or it's a multigenic complex autoinflammatory disorder, and it's a crossroad of autoinflammatory and autoimmune disease. As you know, that autoinflammatory predominantly affects the innate immune system, and mainly through activation of phagocytes, but here it's both innate and adaptive immune system. So clinical features, what I've underlined is most commonly ones which you've seen: fever in 100%, about 102 degrees Fahrenheit, and daily spike you see, or twice daily. It's arthralgia rather than clinical synovitis, up to 100%, and they can evolve into the destructive symmetrical polyarthritis with classical what we call as intercarpal ankylosis. And in 80% of cases, you will have skin rash, which coincides with fever rash or salmon pink typical skin rash. Sore throat is an early symptom of AOSD and occurs in about 70% of patients during the first month of each disease flare. Other features which you see less common, up to 45% of myalgia, lymph nodes 50%, splenomegaly, hepatomegaly, some serositis, including pleurisy, pericarditis, weight loss, and abdominal pain. So as you can see, it mimics several things. It mimics autoimmune diseases like lupus, it mimics malignancies, infections. So that's the difficult part here. So cardinal symptoms, as I told: skin rash, fever, leukocytosis, neutrophilia, arthralgia, arthritis. Other manifestations: odonophagia, myalgia, myositis, lymph nodes, serositis, hepatitis, raised ESR-CRP, increased ferritin, and decreased glycosylated ferritin, coagulation disorders. The complicated ones where you lose patients are these, that is with cardiac involvement, pulmonary arterial hypertension, necrotizing hepatitis or fulminant hepatitis, macrophage activation syndrome are also called reactive histiocytic lymphocytosis or RHL, and DIC or TTP like picture with microangiopathic hemolytic anemia or even rather thrombotic microangiopathy, TMA types of manifestations. So if you look at the biomarkers, which there are several of them, but one I would highlight in the interest of time would actually, if you see quite high sensitivity and specificity to a combination of ferritin greater than 5 times upper limit of normal, that is about 1000, and glycosylated ferritin less than 20%. That combination would give a good biomarker. Rest all to mention CRP, then calprotectin, procalcitonin, and serum secondary amyloid also as well. So if you look at the non-routine biomarkers, again the one which usually is carrying high sensitivity specificity is IL-18 levels greater than 366 nanogram per liter. Rest all are to be mentioned, which I've already told, IL-6, TNF-alpha, and chemokines as well. Now in lab findings, you see that ESR-CRP is in virtually 90 to 100%. It should be high, and high neutrophils and leukocytes, total leukocyte count. Other features of anemia, thrombocytosis, all features of inflammation, and 5 times above the ferritin upper limit, and combining with glycosylated ferritin less than 20% increases its specificity. So you see transaminitis in up to 65%, although it's very mild to moderate. And what you would see in bone marrow is a reactive inflammatory bone marrow, nothing more than that. And you would see in the lymph node, as I told, in our patient with immunoblasts, scattered large B and T immunoblasts, and reactive lymphocytic infiltrate. And you have in about 40% of patients who have chronic AOSD developing intercarpal, carpometacarpal joint space narrowing. FDG PET is useful in actually in terms of ruling out solid organ malignancies, large vessel vasculitis, and also the hypothesis of any major infection. These things are the ones which you have to look carefully in your patients who you are treating if they're developing any of this macrophage activation syndrome, where all the patients with leukophilia and neutrophilia suddenly starts having rapid change in hemography. So that is resolution of high leukocyte count. In the context, they will become anemia and thrombocytopenia, cytopenia, decreased ESR, increased transaminases, high LDH, high triglycerides, ferritin, and you see hemophagocytosis on bone marrow. Most of these patients rapidly you lose them. Very high mortality, nearly 80%. Supportive care in ICU, exclusion of infections, you need to co-treat, and of course you need to think of high dose steroids, or if you have to think with IL-6 inhibitors and etoposide or cyclosporin. DIC is something these patients have prolonged PT, APTT, INA, and low platelets, decreased fibrinogen, increased FDP products. Again, they have to be managed in ICU with supportive care and high dose steroids. So multi-organ involvement in DIC with multi-organ failure leading to high mortality in such cases. You also have thrombotic microangiopathy or Moscovitz syndrome with features of TTP. You can see along with ischemia, with cutaneous gangrene, arrhythmias, multi-organ failures, confusions, including seizures. What you see is MAHA on the blood smear, and thrombocytopenia and multi-organ failure, mainly kidneys and CNS. So supportive measures again with plasma exchange would be vital in these patients, along with other supportive therapies such as IVIG or IL-6 inhibitors. Fulminant hepatitis leading to sort of almost liver failure in a matter of few days, where you see hepatomegaly, jaundice, and very high transaminases. Liver biopsy, if performed, shows protein infiltrates with extensive lymphocytic plasmas infiltrates and hepatocyte lesions with massive necrosis. Again, ICU care is vital here, and rule out other complications and rule out viral activation, reactivation in these patients. Okay. Cardiac complications to summarize is, in terms of massive tamponade, so you'll have to involve cardiologists with, myocarditis features. IVIG can be quite useful here, and you might have to think of ECMO care as well. pH with raised right heart pressures, and close monitoring with vasodilatory therapy and immunosuppressive therapy, coexistent therapy might be needed. What's important for diagnosis, although it's not diagnostic criteria, is it's a classification criteria, is to remember the parameters, that is major, minor criteria and exclusion criteria. Exclusion certainly have to rule out infections, malignancies and other rheumatic diseases. Very important before you actually pen down as AOSD. And with fever lasting for 1 week or longer, arthralgia or arthritis 2 weeks longer, typical rash, leukocytosis about 10,000 with 80% polymorphs. 5 or more criteria required, out of which 2 or major should be there. So fairly high sensitivity and specific accuracy, where you can say, yeah. So differentials, you must rule out infections, as I said, then malignancies, including lymphoma, Castleman's disease, and also drug reaction with DRESS syndrome. So you would need, several infectious serologies, blood cultures. Definitely PET scan is needed to rule out, malignancy or lymphoma. A bone marrow examination is crucial. Lymph node biopsy is needed. You would need all this before actually immunosuppress these patients. Again, autoimmune diseases, much of these mimic lupus, so you need ANA immunofluorescence profile, even dsDNA by ELISA as well. And systemic vasculitis might be, it has to be ruled out, including autoinflammatory diseases you must think of the family history if it is there. And other infiltrative diseases such as Kikuchi, then sarcoid and neutrophilic dermatosis. So generally 3 patterns has been described: monocyclic, polycyclic, chronic. Monocyclic is self-limiting, median about 9 months. Most patients become asymptomatic within 1 year. Polycyclic or intermittent with multiple flares with systemic or joint symptoms and weeks to couple of years. And chronic as well usually have polyarthritis features. So you can fairly say 30, 30, 40, 30% with monocyclic, 30 polycyclic and 40 chronic AOSD. So usually it's benign or non-fatal with a low mortality rate, but if they develop complications, usually 80% mortality. What has certainly found is very high inflammatory markers usually associated with poor prognosis, a high relapse rate. Thrombocytopenia at the onset would be heading for macrophage activation, and very high ferritin level, about 10,000 or so. You must think of complications at that stage at the start only. So NSAIDs certainly has no role, but you can, before you actually start steroid, you can give to control symptoms. If you're using indomethacin is what papers say, and only, it has symptom control role only, and it's never to be used as a mainstay of treatment. And steroids are effective in controlling the disease in about 65% of patients. Initial dose should be 0.8 to 1 milligram per kilogram, not 0.5. So usually achieve very good symptom control. IV steroids has to be considered if they are not, showing any remittance in terms of symptoms, especially fever. So it occurs quick within couple of hours or days. So tapering usually start at 4 weeks. Don't taper as in other diseases, otherwise they'll relapse. But steroid dependence, look at this. One of the reasons to have this CME was this: 42 to 45% of cases. And it's seen with splenomegaly, low rate of glycosylated ferritin, elevated high ESR, and young onset. So early steroid sparing treatment is usually better, and in cases who they don't respond to prednisolone, you might think of dexamethasone as well. So methotrexate is a good steroid sparing agent, as we use that in several other diseases, so we're comfortable with, especially in chronic articular AOSD. In 40 to 70% of cases works as a good steroid sparing agent. And I knew normally you consider adding after 4 weeks, and liver abnormality should not discourage you, but close biological monitoring is required. Cyclosporine is something you consider if you can't use methotrexate. TNF inhibitors, basically has some role in polyarticular refractory AOSD. Although head-to-head comparison is not there in TNFs, but Infliximab is generally what is people have used. They're useful in 50% of cases. Thinking about IL-1 blockers, anakinra is a recombinant IL-1 receptor antagonist, especially with autoinflammatory diseases, has got more experience than stills. Its efficacy in AOSD about 100 mg daily subcutaneous injection. Its main role is the blockade of IL-1 beta, which is the key pivotal role involved in pathogenesis of this disease. So it's rapidly efficient, frequently well tolerated, but expensive phenomenally, and daily regime, and thereby, basically other agents such as canakinumab, which is basically a MAB, which is monoclonal antibody for IL-1 beta, every 2 monthly, which you can use, or rilonacept, which is basically a soluble dimeric fusion protein, once a week dose. So the beneficial effects were seen more with IL-6 blockade with respect to chronic arthritis pattern, and involved in systemic symptom improvement also. So if you talk about the IL-6 inhibition, so it's a suitable target basically because of the IL-6 induced ferritin, rashes, fever. So what we normally are in usage is the IL-6 receptor antibody, that is blocker, that is Tosalisima, with beneficial effects is seen even after 6 months of treatment cessation. And so you see that response is seen rapidly, and experience is seen sustained clinical remission over treatment even after follow-up as well. The only RCT we have is actually in Sogia, or hence have not put up the data, which is not relevant to adult stills. So it demonstrated nearly, it worked in about 85% of children with pediatric onset of stills. So you can actually possibly extrapolate and use them for those, especially if you're not able to reduce steroid and methotrexate is not working. So this is the flow chart, which I'll show you then which paper, which further reading would help you. So NSAIDs during workup, you basically use the items or parameters in Yamaguchi or Fortrell criteria, where you hone in on the diagnosis and rule out the vital exclusions, and you give steroids 0.8 to 1 milligram per kilogram, either IV or oral, and steroid sparing start with methotrexate when you see first sign of steroid dependence, especially young age splenomegaly, low glycosylated ferritin, large increases in ESR. Now in refractory OSD, if it's chronic arthritis pattern, consider tocilizumab or TNF alpha inhibitors or anakinra. Systemic OSD, where very high fever and ferritin and rashes, think of tocilizumab, and because not wide availability of anakinra or canakinumab in our country, so tocilizumab certainly can be used. And in complications, certainly you have to use several agents, that is, steroids, IVIG, antibiotics as a protection, then plasma exchange if there are features of TMA. So this is a proposed therapeutic strategy in stills. In our case, my classmate's sister, so we gave IV Solumetrol 500 3 consecutive days. She became afebrile, followed by 60 mg per day of tapering dose. At 4 weeks, she was on 30 mg pred and started on methotrexate 10 mg. Then ESR dropped down from 102 to 36, and CRP from 150 or so to 31. Ferritin dropped down from 1800 to 604 at barely 4 weeks. At 8 weeks, when I started reducing further to around 20, she started flaring up with high ferritin, high ESR, CRP. That's when I spoke to them about tocilizumab. Started with IV 400 mg monthly, along with I kept methotrexate. I did not want to withdraw that. After first dose, barely ESR, look at the CRP less than 3, ESR became 11, ferritin was normal. She was off steroids. Within a month I could take her down, and methotrexate was escalated 15 mg. She did very well with 6 doses of tocilizumab, and Cipla was very helpful in giving the 1+1 offer, which normally they give for rheumatoid. So, I could, give her 3 free vials, and methotrexate maintenance was continued without steroids. But what she has now currently developed is more of a chronic pain or fibromyalgia features needing pregabalin and Ultracet, which she is struggling but she's back to her physical activity. She was quite athletic. She's been doing that. So methotrexate maintenance has been continued on 10 mg because whenever I flared up the bed, tapered it below 10, she started having flare in inflammatory arthritis. So what started as acute now is chronic AOSD with fibromyalgia kind of features. That's what I would say with respect to my classmate sister. So take home is it's a complex autoinflammatory disorder, and it's at the crossroads of autoinflammatory and autoimmune. Highly symptomatic systemic onset fever with rashes. Usually we rely on physicians to refer us at the right time, which they do. We are very grateful for that. And it's, once you treat, they evolve into a chronic articular pattern, and usually prognosis is good if you identify early and treat. And corticosteroids are the mainstay with IL-6 inhibition and methotrexate as one of the steroid sparing agents. So this is something which you have to read. It's an old paper from 2014 autoimmunity reviews, but great in-depth description of AOSD in this. Thank you very much, friends. So I would now request Professor Raman to actually some pointers where probably you thought you could add on this.
I think, thanks Vijay, it was a very detailed and comprehensive presentation. The only thing that I would wish to say is that as far as our experience is concerned, you are aware that it started way back, the first Annals of Rheumatic Disease paper published by Dr. Bambri in 1992, PJ experience. I think this again is a challenging disease in line with the others that we've discussed since morning. The couple of things, sometimes they present with amyloidosis, and the residents especially have a belief that only biologicals are the ones which probably are useful, like especially anti-TNFs. But we have a patient who was diagnosed to have renal amyloidosis, biopsy proven, with 12 grams of proteinuria, diagnosed I think somewhere in 2003-04, was managed with methotrexate alone, and over a period of time, I think it's almost, you can see 14 years of follow-up. Even the amyloidosis, the proteinuria has disappeared. So it is not what drug we use, it is basically what drug, how effectively we use that drug is what is most important. I think that is what the message that I wish to give. I think otherwise you've very brilliantly shown all the options. I wish we have anakinra also available in India easily, which is a key drug. The rest all, I think you've very beautifully covered the entire topic. The only challenge sometimes is when they present with fulminant hepatic failure, FHF, that's a nightmare. And other times is that differentiating AOSD with HLH kind of presentation from sepsis becomes a nightmare again. So these are the two things which really test your skills. Otherwise, most of the things are brilliantly covered. I think they have driven home all the points which are required. Thank you for asking me to be a part of this wonderful seminar.
Thank you very much, Aman. Professor Raman. So they think about a few Q&As. I would request all panelists to unmute yourself and your audio and video, please. So, Dr. Raj, what is the gold standard diagnostic workup for tracheomalacia? Dr. Romi from Manipur, Imphal has asked you this.
I think biopsy. Again, I'm not very sure about it, because whatever few cases which I have seen, they have been diagnosed on CT. I think for an initial pickup, when you have a patient presenting with only an auricular inflammation or a nasal bridge inflammation, if you want to figure out that maybe a PET CT will be a good to pick it up. But again, when you have a suspected clinical symptoms, I think a contrast CT should help us. Then later on, I think for one case, like with contrast CT and then later on biopsy, also doesn't have a specific features of it. But one patient of ours have been diagnosed like that. Look, maybe this is all I know. I think Dr. Raman can add on this.
Yeah, Professor Raman, you wanted to come in, please.
Yeah, I think Raj, as you beautifully said, in today's world, probably if you have a investigation like PET or a dynamic CT, we would really avoid, maybe if we can do away without biopsy, I would say, because even doing a biopsy has its own challenges because airway collapse might occur. If you have classical CT features where you have anterior two-third showing involvement only on CT and with the posterior one-third which is spared, it is quite classical of relapsing polychondritis. And if you have a PET showing even if CT with CT you can make a diagnosis. If you have PET, it adds on to that value. And with this NIH paper now, I think if there are other features. Occasionally we may have if there is only airway involvement. But I would suggest that with that kind of a radiology, two-third, one-third, probably you should start treating because maybe taking a biopsy might be more dangerous occasionally. I mean, that's my. Occasionally it may be. And the other thing is that the yield may be smaller because from trachea and the biopsy findings which are there, as you have beautifully already clarified, may not be very specific because you have relative absence of basophilia and degeneration of the cartilage. The only differential in that scenario of CT is the amyloidosis. But amyloidosis would have circumferential thickening of the entire airway, whereas the relapsing polychondritis will only have anterior two-thirds.
Okay, thank you very much, Dr. Aman. Dr. Arvindan from Tamil Nadu has two questions for Dr. Sham. What is the role of infections in triggering GCA? What is the best DMARD steroid sparing for patients who cannot afford biologicals?
So with regards to infections, yeah, there have been theories. I think there is more evidence for this one. What is it? Herpes zoster, then some for mycoplasma, parvovirus, and other things. But as we know, like it's not like it's a definitive this one. With regards to the next this one, what is the steroid sparing agent? Definitely methotrexate has been conditionally recommended if the patient is not able to afford Tosalisima. And there is very minimal data for azathioprine if not next to methotrexate.
What is your opinion on JAK inhibition in PMR? I have found this quite useful with generic TOFA. They're working. I mean, the steroid dependence have come down. I don't know what you say, Sham and Dr. Aman. What is your thoughts about JAK inhibition?
I haven't used, Vijay, in PMR. I haven't used JAK.
I haven't used either. So,
out of desperation, when they can't afford now, you got to throw something to them. So, JAKs have been safer so far in terms of course, in the age group, you have to be careful with respect to cardiac history and malignancies and all those, which we would have ruled out anyway. With especially if steroid dependence is there, the flaring up, you would have ruled out in terms of imaging for malignancies. But I found that TOFA has been working. Baricitinib I tried, not working well, so that's where I think. What about for large vessel vasculitis, Dr. Aman? What about JAK inhibition?
Again, I think my experience, we haven't used JAK inhibitors in large vessel vasculitis. The Takayasu, if you talk about, which is more common, the drug of choice again are you see the methotrexate, MMF, and even anti-TNFs. There the choice is anti-TNFs. We've done Durga has recently done a systematic review, which probably got published yesterday. That will be valuable. I think it is coming in clinical rheumatology. Highlight all the evidence in favor of all the biologicals. I think it's more strongly in favor of anti-TNFs.
For large vessel vasculitis, you mean?
Yes, for Takayasu especially.
Takayasu.
Okay. Yes.
Okay, great.
But GCA trials are ongoing, Vijay, like with Barry and upadacitinib, then RCT is there, it's ongoing.
I think there is some data on leflunomide also in GCA.
Yeah, leflunomide
where methotrexate is intolerable. I think leflunomide quite easily we can use.
Leflunomide, Dr. Bhaskar is a strong advocate of use of leflunomide both for GCA and even for PMR. Yeah. Rather, his choice is to use leflunomide ahead of methotrexate in PMR.
I have two patients on leflunomide, quite a good steroid sparing agent. We can bring it down to less than 5 milligrams per day, almost alternate days, and they're doing quite well on leflunomide because both of them were intolerant to methotrexate after a few months.
Okay, so it's a couple of quick questions we'll finish. So this question is to Dr. Neeraj from Dr. Suvrat Arya from Noida. Uttar Pradesh. Role of surgery in debulking orbital residual IgG for RD.
Actually, in our experience, we never needed actually, because everyone responded, majority of them responded to steroid and steroid combinations, and those who didn't responded, they responded to rituximab. So in our cohort of patients 70, we didn't come across any patient needing surgery, because I think personally it won't help. It won't help. So it's best to try all your possibilities, and maybe, I think maybe follow-up will tell if some patient needs it.
Great. So, Dr. Arvindan asked me about JAK inhibition in AOSD. I have not tried. I mean, these are serious patients, so probably you would need something stronger. So, JAK is something I have not tried and something we don't know at all. And last question is Dr. Sri Harsha from Telangana, Secunderabad. So, we recently had one AOSD case incidentally detected COVID positive. Managed him with IV steroids, extended remdesivir, discharged him on oral steroids and methotrexate. Contemplating on Tosalisima on follow-up. This is a bit difficult post-COVID. I mean, I would say that, you know, if Tosalisima, I would personally use if not able to reduce steroids at all, and you've exhausted all other options, and steroids is requiring more than 30 milligram per day or even dexamethasone you're contemplating, then I would probably use. Otherwise, no experience. What are your thoughts, Professor Raman, about this question?
I think same. It goes with what the example that I gave. If we are able to manage with steroids and methotrexate, in every patient, these drugs may not have added advantage. Some of them we will be able to treat with methotrexate, and that was the reason that I gave that example. Now we have 13 years of follow-up, and methotrexate has done very well.
Okay.
Definitely.
But I think we have come to the end of the session. It's almost 45 minutes late. I thank all the panelists, especially Professor Aman Sharma, to have kindly spared his Sunday for us. I see that he's hungry. He's probably eating something as well. So I'm very, very grateful to all of you and to all the attendees. I'm ecstatic. Mainly I lost a few patients and I felt guilty that somewhere I should team up and, you know, pull the brains together and discuss this. So I think I've done justice to the departed souls.
Yeah, nice initiative. Very nice initiative.
Yeah, I think it's a very wonderful initiative because we have to learn from each other.
Right.
Because these are rare diseases, and even if I might have seen something, you might have seen entirely different.
Definitely. Spectrum.
Yeah. It's only when we put the pieces of that puzzle together that the entire picture might become better and clearer. So I think it is cumulative experience of each one of us which makes the lives of the patients different.
Yeah.
Definitely.
Thank you. Last but not the least, I thank CIPLA team for putting this platform together. Even at the last minute, they agreed in the interest of science. I'm very grateful to them. Over to the CIPLA team to end the session, please.
Thank you, sir. I won't take much of the time, sir. Just wanted to appreciate the efforts that you have taken to do this meeting. And we have got the very huge response from the audience from all across India. Almost 140 doctors connected today, and they were there till the end. And we have got a very good response, sir. So all credit goes to you, sir. Thank you so much, sir.
Credit goes to the panelists and to Professor.
No, thanks to everyone actually.
With a lot of passion, you have done this CME. It clearly shows that with a lot of passion and emotion. You have made this CME.
So mainly my some tribute to the departed.
It's not like a routine, regular CME. It shows the passion and the last moment entry of Dr. Aman is just like a ice.
That was wonderful. That was wonderful.
That sort of gave the icing very nice.
So it has made complete picture. Thank you everyone.
Thank you all. Have a nice Sunday.
Thank you so much.